Welcome everybody to this G-CEM Europe webinar. A special welcome to the people who are logging in at home, and I hope you are well settled in your chair or maybe in your sofa. We'll be speaking today about biomimetic dentistry and especially about ceramic veneers cementation systems. And I would like to have today a very daily everyday dentistry insight on the subject, and we'll see also some studies giving some justification to what I am going to tell you. Speaking about indirect restoration, we just have to thank first of all the technicians who are working with us, and the cases that you will see in this presentation were done by Samuel Schwab, Bernard Landweiter, Grégoire Martin, and especially Jem Piskin. Jem Piskin is a fabulous ceramist working in Lausanne, Switzerland, and he's part of the group of the bioemulation group. Maybe you've heard about that group. And I'm talking about this group because today it's not only a one-person presentation. It's not my presentation really, but a group presentation. And a lot of people in this group, which is promoting biomimetic dentistry, helped me doing the presentation, and you will see some pictures which can be credited to other people of this amazing group. Before we start, I would like to do a small disclosure. As you know, this presentation has been sponsored by G-CEM Europe, and in the past I just had financial compensation by other companies, but I have no commercial interest with any company at all. And very important point, and very interesting for you, that all the cases in this presentation are carried out on fee-paying patient in a private office. It means that the cases of today are about everyday dentistry. What I did is not book the patient in especially for this webinar or for our presentation, but just book a regular patient in, and as the treatment goes along, just grab my camera and took some photos. So I think that it will look more or less exactly the same that you have in your own office, and this is really important. Regarding the pictures, there is absolutely no Photoshop except from other than straighten, crop, exposure, and some very classical corrections. So there is no transformation made by Photoshop, and all the cases were done by myself or credited to other people. The only question which is interesting for you is, are those restoration veneers, ceramic veneers especially, safe restoration? Because if we're used to do crowns, peripheral preps are reassuring us because you've got geometry. Speaking about veneers, you don't have geometry anymore, and to be honest, we all are a little bit scared about this. Will it be safe? Will it bond? And then we just have to turn ourselves to the literature, and I would like to thank you, Marco Gresnik, which did his PhD especially on that topic, and it helped me a lot searching in the literature some infos for you. And if we look at some papers on the success rate of ceramic veneers, we see that more or less after 5, 10, 15, sometimes 20 years, the success rate is very high, or the failure rate is very low, maybe between 5 and 10 or 15%. But within those studies, you've got one done by the Brits, which is jumping out because more or less 50% of the cases done by this team failed after 10 years. So this is a lot. What does it mean? You have to know that for this precise study, for this specific study, a lot of restoration was done, but within the National Health Services regulations of Great Britain, which means that a lot of different dentists did the work on a lot of different patients with a lot of different skills and way to do it, and it means that those restorations are very sensitive, are very demanding and very sensitive to the operator factor. So that's why it's very interesting for us to know exactly the rationale, the procedure, the safe procedure to do it. Because if you do it wrong, you will have 50% of a failure, which is not standable. Well, that's why the menu that I'm suggesting to you is quite simple today. I just would like to address first, what do we need to meet security? And then how to do it, clinically speaking. So very basic, very, very simple. What do we need? As I said, we don't have any geometrical anchorage on the tooth. So we need an effective bonding on the tooth side and on the ceramic side. Then we need aesthetic, because those restoration are at the front. So we need the cementation, we need the whole restoration to be aesthetic, of course. But as globally speaking, it's quite demanding, quite tricky procedure. We just want the cementation to be very easy to handle with. So how to do it? And finally, we want the restoration to last for long, because it's so demanding. I don't want to redo it tomorrow morning. So I want it to be long-lasting, of course. Let's address the bonding and some point of it. On the tooth side, what can we do to improve the security, to improve the bonding? Well, first of all, I would say it is not about cementation, but about preparation. When we prep the tooth, if we try to preserve enamel, we will meet a higher security, because we know that on enamel the bonding is very easy to get and is very effective. But, well, it seems very easy to say, stay in enamel. But as we are used to prep for crowns, for example, it's quite easy to remove a lot of tissue. It's not easy to remove only a very few part of the tissue. So staying within enamel is absolutely not that easy, but must be one of our main goals. Then, if you meet the dentin, if you drill too much, or if you redo a treatment and the dentin is already exposed, to promote the adhesion, you should hybridize the freshly cut dentin. This procedure is called the immediate dentin sealing. Is known for the early 19, was introduced by Pashley, and then with the Swiss team with Dici, mine, and also the German steel with Paul and Scherer. And the point is that if you cover immediately the dentin that you cut with a bonding layer, it will improve the global bond strength. So, on the other side now, on the ceramic side, what can we do to get an effective bonding? And this is a very interesting study here done by one of our mates of the group, who is Lucas Naves. Lucas is a young, brilliant Brazilian professor, and he did in 2010 a study with his team about the way we could condition the inner surface of the ceramic veneer to improve the bonding. So what they did, they just took different time with the etching, different etching pattern, and different time for etching, and different covering with silane and sometime with resin. And they get to the conclusion that, well, you don't need to increase the time of etching to get a better bonding, because you transform the surface and maybe you will alter the surface of the ceramic. So you have an ideal etching time depending on the type of ceramic that you are dealing with. So you just have to refer to get information from the manufacturer and to respect very strictly those information and recommendation. And then if we apply on the top of the etched ceramic a layer of silane, it will improve the adhesion. And furthermore, if you apply on the top of this, and those are scanning electron microscopy pictures, SEM pictures, when you see that they covered the silane surface with a thin layer of unfilled resin, and it improves the bonding because it penetrates all the irregularities that you've created with the etching. And furthermore, it also will reinforce the ceramic. Why? Because effective bonding and reinforcement of the ceramic are two concepts going close together. Once it's effectively bonded, it's strong. And if the resin comes inside all the irregularities, in all the flows of the inner part of the ceramic, which are very, very often the initiation of cracks and of problems, you will improve your bonding, and at the same time you will improve the resistance of the piece, so which is quite interesting, and we have to keep that in mind. Second point, the cementation and the restoration in itself has to be aesthetic. The question is, if I'm ready to cement a veneer, could I do something with the choice of my cement to improve the aesthetic? Example, you have this case to treat with one tooth. The treatment plan is to do 2 ceramic veneers on the 2 front one, or the 2 centrals, and 2 composite direct restoration on the laterals. I just have to mask to cover the dark substrates of tooth 1-1. And the other one, the 2-1, is just lighter. Can I do that with my cement choice? Should I choose a different cement for the tooth 1-1 and for the tooth 2-1? Or should I do that with the ceramic? My opinion is that the final result starts already at the time of preparation. So once again, we just have to preserve enamel, because the deeper you go, the deeper you cut, the darker you will become, because this is the dentin, which is dark. So we have to stay in enamel. You do your IDS, your immediate dentin sealing. And then, very important point, you just record the color of the substrate, the color of the tooth, because the technician has to know exactly the shade and the color properties on the substrates he will work on. And I truly think that this is the technician that will mask these dark substrates. We don't have to do anything with our cement. So what I think is, as long as you have a veneer, the literature say 0.5 millimeter thickness. I think that 0.7 is maybe a better value to keep in mind. So if the veneer is thick enough, you will cover everything, as long as your technician knows exactly what he has to cover. And he will deal with the ceramic, with the opaque inside the ceramic, and you, at the time of cementation, you will use exactly the same shade of the cement. Same for the 2 tooth. Because if you don't do that, I think that personally, it's completely random. I choose this or this, I try to cover and to change the color. It's absolutely not predictable. So try to make it simple, choose the same color for different substrates, and the ceramist is in charge to try to mask it with the ceramic itself and not with the composite cement. And this is what you have finally with the direct and the indirect restoration, and everything looks pretty nice. You don't see any difference anymore with different materials and different ceramics. And this is all about this, but nothing to do with the cementation really. If you want to go a little bit further in this topic, we still have to choose an aesthetic composite cement, because it is so much at the front that we will see somehow the margin. So which one should we choose? It is pretty clear that the conventional cement, like water-based cement, ionomer cement, resin-modified ionomer cement, are absolutely not suitable for those procedures. Even if it does bond, it does not bond enough, and the aesthetic properties are not that performant to meet the results that we want to have. So we have to choose, no choice about this, the resin-based cement. No ionomer, no resin modified, never. But then, you've got a lot of different ones. So which one to choose? Because you know, the manufacturer, they know that this is a very difficult procedure, so they've tried to facilitate this procedure, and they introduced in the market 10 years ago, 15 years ago, some new product. It's resin actually, but it's quite hybrid resin with hydrophobic component in it, very classical one, and with also hydrophilic component in it, just to make it to allow you to handle it as easy as the conventional cement. But it does bond because it is resin. Unfortunately, those products, those hybrid products, which are also called the self-adhesive cement, are not that performant, and are not that aesthetic. So I wouldn't recommend you to use those products, and prefer, please, the hydrophobic, very classical, conventional composite. And if we look at this study, which is very interesting, you've got a lot of different brands, and the topic is here is not to say, okay, you don't choose the G-CEM, choose maybe the G-CEM because the values are better. It's absolutely not about this. The point is that all those different brands, all those different families with the self-etch, the self-adhesive, the etch and rinse, all those composite cements, they just show us values which are not that good compared with the direct composite one. So just keep in mind that the control is the study, the gold standard. We want to have the strongest values. So why not choosing the classical direct composite that we already have in the office? Why do we have to buy a new one specifically to bond ceramic veneers? Keep that in mind, and we will go later on this topic. To be honest, I never used myself self-adhesive composite resin to cement veneers. I never dared to. But I did some cases at the posterior, and this is a very, very short follow-up, 3 years follow-up, and you see already the catastrophe, this orange line. So discoloration means hydrolysis. Hydrolysis is due to the hydrophilic components which are inside, and it means leakage, maybe in coming years some secondary decays and so on, and it means anesthetic. Imagine the same situation at the front will be a real catastrophe. So please don't use self-adhesive composite resin. Then, if we use composite resin, hydrophobic ones, which shade? Because we've got so much different shade. And the temptation is to use a translucent one. Because we say, okay, we'll try to make it aesthetic. We want the light go through. Let's use a translucent one. Well, unfortunately, with the translucent shades, you will have some kind of gray line at the margin if the margin is visible at the day of cementation or a couple of years later. So I should advise you to use preferably dentin shade composite, not opaque dentin maybe, but just regular dentin, and the same shade as the substrate. If you have a substrate which is A2, choose a A2 dentin shade. Very simple, always the same rule. And then the final question about the type of luting cement is what curing mode? Because you've got two curing modes. You've got the dual cured and you've got the light cured. Why is it problematic? Because the dual cured, sometimes we can just think that dual cured is good because if my curing unit is not that powerful, if the veneer is very thick, I've got the security because you've got it will be cured anyway without any light. Okay, but the problem is that some papers in the literature claim that you can get problems with some discoloration of the margin with the dual cured, especially because of the chemical components in it. And I won't go further into the details. That's not interesting. Let's stay clinical. And some other studies claims that, okay, there's no difference. Anyway, you will have some discoloration and with the light cures one and with the dual cure, so you can use both. And this is a very interesting final study, just to say, okay, you can use both, but however, for those unwilling to take risk, do you want to take some risk or not? I don't. In front of an observer with more accurate visual perception. What is this? Every patient has a highly accurate visual perception. He wants a perfect result. So please, if you want the security, use the light cure composite and not dual cure. And this is only one example. For example, at that time, I've got several curing units in my office, and the one I prefer, the most powerful one, was just broken at that time. So I just have the old one, which is not powerful, and with thick veneers, and I used dual cured. cement. After 5 years, this is what you have. Even if the patient is a heavy smoker, even if it's a red wine drinker, you see clearly the margin which is completely discolored. Okay, the patient didn't mention it, but okay, we can see it. So I can prefer to use the light cure cement every time when it's possible. And regarding the next point, the handling, with the light cure composite, you've got plenty of time to work with. With the dual cure, you're just in a hurry because the cement is just setting by itself. Well, easy handling. What does it mean? We just want the veneer to get into position very easily. And this is the main problem because, as I said, you don't have any geometry. So you don't know how the veneer will just fit on the substrates. And it's regarding the viscosity because all our luting cement, they flows over the margins. So we naturally think that, okay, a flowable viscosity will be better and will be easier to handle. Okay, why not? Regarding the positioning, you will get to the final position maybe easier with the flowable composite. And regarding the thinness of the veneer, because a very trendy tendency actually is to have thinner and thinner veneer. I don't know if it's a good idea, but this is the way things are going right now. And if you have such like a contact lens veneer, it looks so fragile that you see, okay, I don't want my cement to resist to the pressure. It has to be flowable. Okay, let's see a case about this. This is a lower case, very thin feldspatic, so very fragile veneers, maybe 0.3 millimeters thickness, something like this. And those are the preparations. And in that case, I was just a little bit scared to fracture the veneers by positioning it, or them. So I choose a flowable cement. And as you see, you've got the illusion that it is very easy. You can just put the veneers and do the settings and it's okay. 1 week after, just 1 week after, I had this very bad surprise to see that 2 of the veneers, you only see 2 of the veneers on the screen, but believe me, there are 3 which are already fractured and fissured, and this is a disaster. The patient didn't see anything, but I can see it, and I worry a little bit about this, and the question is, why? Well, maybe it's because I did wrong. I did something wrong. I was too pushy, too violent, I don't know what. Maybe that's a possibility. Maybe the ceramist did some mistakes. Building the feldspatic ceramic, it's a very tricky procedure. Maybe he did something wrong and the ceramic was not good. You had already fissured inside at the beginning. I don't know. That's a possibility. But my opinion is that with those very thin veneer, when you don't prep so much, the fitting of the veneer is not that good. It means that the thickness of the cement is very big. And then if you use a flowable composite, every flowable composite are shrinking more than the viscous one. So you have thickness, it means volume of composite, shrinkage, fragile veneer, feldspatic veneer, thin veneer. This is a fabulous cocktail to meet maybe fracture because we think, and we are wrong, I think that speaking about veneers, you don't have any problem with the C factor, the configuration factor of the preparation, because it's more or less flat. So you see, it's not like at the posterior, when you've got complex cavities and complex C factors and tension and stress everywhere with the shrinkage. At the anterior, there is not a problem. It's true, but just remember that when the thickness of the luting cement is increasing, the stress is increasing. So this is a factor that we have to take into consideration, unfortunately, because if the thickness is more than 30 or 50 micrometers, which is nothing. It's impossible to get a margin of 50 micrometers with a composite resin anyway. We have usually between 200 and 400 micrometers thickness for our cement, which is huge, and with this kind of thickness, you will have shrinkage and tension. Let's take a look at this other very famous study of Pascal Mine, done in 1999, and it's a comparison between the thickness of the prosthetic piece of the ceramic and the thickness of the luting cement and the tension between both. And it clearly indicates that as soon as your veneer is thicker, maybe 2 times thicker, 3 times thicker, so you have a rate of 3:1, for example, you are in a security zone because you won't have any tension, because the veneer will be more resistant than the tension induced by the cement. But as soon as the thickness of the cement is increasing, and especially when you have a very thin veneer, you've got so much tension that there is a risk for cracks producing inside of your ceramic. So just keep that in mind. Every time we just feel like using a flowable, it's when we have a very thin veneer, because we're just scary to fracture everything. And this is typically the conditions when you can have some problems, especially with feldspathic veneers. So this is a case I would like to share with you about palatal veneers. There is no difference between the palatal and the front veneers. It's exactly the same. And showing you the flowable handling. And when I use flowable, because I use them sometime myself, it's not my favorite one, but I use them sometimes, I should advise you to use and to choose flowable with the highest mechanical property that you can have. And for the purpose, the genial universal flow is a good one to use. So if you see this video featuring the genial universal flow, you can see that I'm trying to position and to get the veneer into position. It's quite easy because it flows very easy, so there is no problem. And you start to eliminate the excess, and you do that with a brush, with whatever you want, taking out the floss. And for the very last amount of flowable, it's a mess, really. And this is, to me, the major drawback of flowable, because it looks easy, you know, it is quite easy, but at the end, you will just brush everything on the margin with your brush. And it's very difficult to get a good polishing afterwards, and it's very difficult to get rid of all the excesses. So that's why it's not the solution I prefer. I show you this other video, exactly the same kind of case, palatal veneers, using this time a viscous composite which has been preheated. Look how viscous it is. And then to get the veneer into position, it's a little bit more difficult, and sometimes you will have to push like crazy, or even to use an ultrasonic procedure to further insert the veneer. But once it's in place, it doesn't move anymore, and look how easy it is to get rid of the excess. Well, you don't have all the advantages with this technique, but I like it so much because I like it. I find it so predictable regarding the final outcome that we want to meet. But this is not the only the only solution. We will come back on this in the clinical part. Finally, if we look at the long-lasting properties of the composite, it is very natural. And regarding the video that we've seen just now, it is very natural to think that the composite, which have the best mechanical properties, which have the best behavior over time. So those properties are very interesting to see, and you will find very, very few studies about this. This is one of those done by a Chinese team, or led by a Chinese Zhang, and done in a very difficult paper to read. But this is, I did it, yes, it was really a mess, but I did it. And this is a study about the load-bearing capacity of ceramic disc. It's in vitro, cemented with different cement, which have different mechanical properties and different elastic modulus, which is one of the main important mechanical properties. And you see clearly, this is the black line, which is quite horizontal, with a very thin thickness of luting composite. You won't have any problem whatever the luting composite you choose, with high mechanical properties or with very low mechanical properties. But as soon as the thickness of the luting cement is increasing, and again, we have very, very thick ones, believe me, the properties of those cement just play a major role. And you see that the ceramic will be much more resistant. This is, for example, the blue line or the red line. It will be much more resistant with a luting composite that have higher mechanical properties. So it's a point that, once again, it's not really studied in the literature, but it's quite natural to think that the best properties you have, the long-lasting restoration you will have. So finally, if we just want to do some resume of what we did, what is the best composite that we actually have? Maybe this is the one that you already have to do the direct restoration. And for example, I'm using currently the genial anterior composite, which is a composite just for direct restoration. Why not to use those kind of composite to lute the ceramic veneer too? This is the point. And now we come to the second point of the presentation, which is how to do it, practically speaking. The procedure that I will describe now is not mine, absolutely not. It's more or less like everything that I've showed so far. Nothing is from myself. I'm just a copy-paster of others did better than I. And this is the protocol presented by Pascal Mine in 1999 that will be described over there. The first point, the crucial point, whatever the procedure you want to use, is to get a proper isolation of the operating field. And this is not a course about the secrets of isolation, but I just want to share with you some of the ingredients of the recipe, of the Stefan Broer's recipe. Stefan is a isolation maniac, I would say, is also member of the group. And this is one of the tricks is teach to me. And we are sharing this patient for the use of dam. Use heavy gauge dam. Punch small holes, but spaced hole, because if you have a lot of latex between the holes, you will be able to cover all the papilla perfectly. And then inverse the dam. It means that you should push the dam inside the sulcus to get the tightness. Then help yourself with some waxed floss ligature and with retraction cords, or with Teflon tape, or with clamps. You've got plenty of different solutions to get the proper isolation. Example, this is the typical situation. If you want, for example, to cement 4 front veneer, you will need Hancock clamps at the very back. I like to use a very large isolation, almost the whole arch, and then to use secondary clamps at the front to help the dam to go beyond the margin, which is not very easy to do. So for the purpose, you will just have to customize sometimes existing clamps. Here I'm using the 212 from U3D, and you can just cut one wing and cut the other one, and you've got one right and one left clamp to use, and you are into position. Let's have a look at this video, for example. So you see that on the lateral, with 2 simple ligature, I just succeed pushing the dam over the margin level. But on the centrals, it's quite impossible. It's quite impossible. Why? Just because there is a huge difference in the height of the margin at the buccal aspect and at the proximal aspect. So for the purpose, I'm just using a clamp to push the dam over, buccally speaking. And I try to push it with my fingers. I will also help myself with a spatula. You will see that in a moment. Where is the spatula? The spatula is coming right now. And trying to push the clamp beyond the margin just to expose directly the margin. But the problem is, at that point, your rubber, the latex, is not in contact with the root. So it seems to be okay, but it's not. And you can use a ligature afterwards just to push the dam and to drive, I would say, the dam inside the sulcus. And you see, I'm just tightening the ligature like crazy, and I push the dam at the same time inside the sulcus to get the proper isolation. Because if you've got a small hole, if the rubber dam is heavy gauge, if the ligature is helping, you will have this contact, direct contact between the latex and the root and the final proper isolation. Then, another point is how to treat the intaglio, the inner part of the ceramic. Okay, we are only speaking about glass ceramic because dense ceramic like alumina or zirconia are not, to my opinion, proper for to bond. So we speak about glass ceramic, that is to say disilicate, that is to say feldspatic ceramic. Should we sandblast it? No, because we have a glass matrix. If we sandblast it, we can just induce and create some little cracks and further problems to come. So to prepare the surface and to make it rough, it's a better idea to use some acid. And especially, you've got a special one for the glass ceramic, which is the hydrofluoric acid. Different concentration depending on the ceramic you're using, between 5 and 9% of concentration, and the time that you will etch it is depending also on the ceramic you are using. So just take a look at what the manufacturer is recommending, and for example, for disilicate, it's about 20 seconds with a 5% hydrofluoric acid, and for feldspatic, it's about 90 seconds of etching with a 9% hydrofluoric acid, depends. After etching, this is what you will get on CEM picture. On the left, you have that surface with a lot of debris on it. And we have to get rid of those debris because we want the bonding to go inside those little irregularities that we've created. And to get rid of those debris, the best solution is to put the veneers in ultrasonic bath with alcohol during 5 to 15 minutes. And this is what you will get on the right afterwards. And it looks pretty nicer and a little bit more proper to ready to bond, I would say. Then, when it's etched, cleaned with the ultrasons, we will promote the adhesion using a silane. Use some layers of silane, let it react for 1 minute, maybe 2 minutes, that doesn't matter really. But then you just have to carefully, and this is a crucial point, you just have to carefully dry your silane because a chemical byproduct of this reaction is water. So if you've got water on the surface, it's a catastrophe with the coming lutein composite, which is hydrophobic, remember? So dry it carefully to evaporate the solvent, to get rid of the water, and also activate the reaction with some heat. You can put the veneer in an oven. It works. You cannot do that with the head of your patient. That's the problem. That's why I prefer to use my curing unit, and I use the Velo one from Ultradon, which is very powerful and which is giving a lot of heat at the top of it. Try on your finger, you will see, to activate this silanization reaction. Once it's done, remember the study of Lucas and coat the veneer with an unfilled bonding. So what is an unfilled bonding layer? It's simple. It's your bonding resin. It's the one that you have in your bonding system. So you just take the bottle number 2 with the hydrophobic resin. You put one layer, you spread the layer all over, and you just let it like this. And please do not cure. Because if you cure this layer, you will just add another something else on the surface, and you won't be able to get the veneer into position. On the tooth side, what do we have to do? It's pretty the same. And what is it the same? Because the substrates are not that different. What do we have to treat? Most of the time, we still have enamel, maybe only enamel, maybe some parts of enamel, and existing composite. Why? Because as it is presented in this case, you have a previous restoration made out of composite. Or you had, at the time of the preparation, some dentin exposed, and then you had covered it with the immediate dentin sealing. So you did that 2 weeks ago at the time of the preparation. 2 weeks after, at the appointment for cementation, you won't get any chemical double bonds between the existing composite on the tooth and the new lutein composite. So you just have to refresh a little bit this composite surface to make it suitable for bonding. How do we do this? The best way to do it is to sandblast the surface, because it will prepare the enamel very good. It will prepare also and clean the surface of the existing composite very good. And I'm using for the purpose the Cojet from 3M device, and which is a very easy sandblaster to use with a special sand, which is the silica coating sand. Because you won't, in that case, only clean and roughen your surface, but you will also create a silica coating, which is a way to promote the adhesion a bit more. We've got a very good paper of Marco on the subject, and this is what it is about. This special sand is alumina grains coated with silica. Once you threw the grain on the surface, the silica will stay on the surface and the alumina will go out. This is how those grains look. Those are more or less about 30 micrometers diameter grains. This is alumina. And if we zoom on of one of those grains, this is what you will see. This is silica, the small balls, and the small balls will stay on the composite. This is the composite surface, which is roughened, as you see, with all the balls over it. The surface is just improved to get a better bonding ability. So once it's done, first sandblasting, silica coating if you like it, you just have to etch everything. We have to etch anyway enamel. Use the edge that you prefer, phosphoric edge, the blue one, the purple one, no difference. And you can just put the edge all over the tooth, because it doesn't matter. On enamel it's very good, and on the composite it doesn't produce any effect. No good, no bad effect. So do it simple and coat everything. And this is the kind of surface that you will have, and thank you to Eric Mortier to give me this beautiful picture. And you see the increased enamel surface, and you can imagine how deep the bond can go inside and why the enamel adhesion is so strong and so predictable. The next step, which is siliconization. What do we do siliconization of the tooth surface? We can understand very easily why we do it on the ceramic side, but why on the tooth? Because you've got silica on it. Or you did the silica coating, and that's why you've got silica on the surface. So this is a good solution to promote the adhesion, because you have silica on the surface already using a silane. Or you have silica anyway, because inside the composite you've got fillers and you've got silica in it. So apply some layers of salinization, exactly the same process, 1-2 minutes, then heat activation with your curing unit, and it's done. Exactly the same procedure. Finally, and this will remind you of what you did on the ceramic side, you just cover all that stuff with a thin layer of uncure and unfill bonding resin, bottle number 2 of your adhesive system once again. And this is it. Both sides are prepared, and you see more or less the same way. It's not that different. So it's also a very, very simple and very predictable, not only I would say a very predictable procedure, but also a very simple procedure for your nurse, because, well, it's the same every time and on every side. So this is good to know. And now the only thing that you need is the luting cement by itself. So, as I said, I like very much in the majority of the cases to use the regular classical restorative composite, but the problem with this composite is too viscous. So as it's too viscous, I just have to modify a little bit the viscosity, and you can eat it. So prefer compule conditioning, because you won't eat the whole syringe every time, because you can't do it 50 times. It will disturb a little bit the matrix. So use compules. I like to use the composite heater from Adent, for example. And then you will heat it to 60-65 degrees. And then you can apply on the two surfaces and get the bonding. Let's see all that stuff with a clinical case from A to Z. This is a very charming patient with 4 front teeth to do. As you see, she had already a composite veneers attempt to, improve a little bit the aesthetic. She wants to improve it a little bit more. So we plan the treatment. I won't go very deep in those details because this is not the topic of today. On the models, you plan what you want to do with the gum, what you want to do with the proportion, and we try every time that we can to add some material on the surface with the walks up, and then you just don't have to reduce so much, and you will get a lot of enamel. Keys are controlling the preparation, and it's very important to use keys. And when your preparation are done, as we said before, you just have to record the shade of the substrate with some photographs. And you can very easily use a special filter to do your shade recording. This is called a polarize, and this is a filter that you simply applied on the top of your flashes and of your objectives. It was developed by Panagiotis Bazos inside bioemulation, and this is not the only one which is doing this, but you can just purchase through bioemulation. And this will eliminate the specular reflection. So it means that you won't have any reflect at the surface. It means that you will see deep inside the tooth the proper shade of the substrate, which is very useful for the technician. Then we move forward with the impressions, okay, nothing special. You do the provisional using the same key that you had to do the mock-up, and this is the day when you have to try your veneer. So to try the veneer, I don't like all the trying pastes that exist on the market, and simply use glycerin gel. You have to put something underneath the veneers to let the light come through and to see exactly, well, how does it look? Is it okay or is it not okay? So use glycerin gel very simply, and you can check if everything's okay. If everything's okay, you just move on and do your isolation. Large isolation, almost full arch, as I said. And then in that case, again, I was able to use simple ligature for the lateral, but not for the centrals. Centrals with clamp. I'm starting with the sandblasting and the silica coating. This is what you have. You make the surface smooth and rough at the same time. Then you go with the etching. Very classical, nothing special, to get even a rougher surface on the enamel aspect. very important point, which is neglect sometimes, rinsing and rinsing like crazy. And this is what you get after preparation and after salinization. Everything that you have to do on the tooth surface is done at that stage. Now we just have to prepare, or maybe your nurse did it in the meanwhile, to the intaglio. So then we have to prepare the inner surface of the ceramic veneer. This veneer was made out of feldspathic ceramic, so I choose for the purpose the 9% hydrofluoric acid applied for 90 seconds. Be very careful with this product, which is quite aggressive, and rinse it very carefully. Be careful with your eyes especially. And once it's done, excuse me, I like to do a final check. Why? Because now you've got two very clean surfaces. The tooth is ready, you've got no bonding, but the tooth is ready and completely clean, and the veneer is ready too. So I like to try it just to make sure that there is nothing which will disturb me at the time of positioning, because this is my main problem. I want to make sure that this veneer will get into proper position. So at that time, you can just apply this and just check if, well, is my clamp disturbing me somehow or something? If it's okay, we'll be okay with the cement too. So I like to do it. Maybe it's only a psychiatric precaution, but I like to do it anyway. Put the silane on the inner surface. We already discussed that point. Some layers, 1 minute. Activation with the lamp, if your lamp is powerful, and then you can put a layer of unfilled resin on the surface of the tooth and of the intaglio of your veneer. And now come the interesting point. This is the preheated composite that you have. This is here featuring the genial anterior. As you see, it's a very viscous, it's a very dark composite, dentin shade, and then you have to push like crazy. And this is a very frightening moment, to be honest, at the beginning at least, but then you get used to it, because the composite is resisting to insertion, yes, of course. So a good trick could be to push with your finger, with your thumb, with the larger surface that you have. This is the best instrument that I have. So push and push and push, and you will see that on the video in a moment. And then you will see that this composite stays hot for, depending on the composite, but for the genial it's about 1 minute, 1.5 minutes. So you've got that time to push hard. This is quite a lot, and you have already plenty of time to push out all the excesses and to get the final adjustment. This is what you have at the final, and then you will cut all the excesses after polymerization, and so on, go from veneer to veneer. And this is for the lateral, and this is what you get finally. So now we have a little video illustration of how it goes. Again, it's done with the genial. As you see, dentin shade, same as substrate, excuse me. I'm just spreading the composite everywhere. So I take my time. You've got plenty of time at that moment. Be careful with the ambient line. Don't put full light on it, because you have a very long walking time with this kind of composite, but still turn off maybe your dental light, and you push. I don't know at that stage if the positioning is correct or not, but I don't care. I just take out the first excess, and then I will push again and again and again. And I've got maybe 1 minute. It's almost, you don't have anything cut on this video. It's almost real time, you know. And I push, take out the floss, because I like to put some floss in the sulcus to make sure that you don't have any composite diffusing in this area. And then with your probe, you simply get rid of the excess very easily because of the viscosity. So same procedure again on the other side. On distal aspect, and then I still don't know if the positioning is okay. Do you see? This is a little bit risky. I'm a little bit maybe optimistic in that case, but it sticks so much at that stage that you can even floss in between the teeth without any risk to make the veneer move. So you see, I just push like crazy once again. It's feldspathic veneer. It's about 0.5 thickness, so it's not that resistant, but there's no problem. You can just push as strong as you want, or more or less. Once again. And at that time, well, I said, okay, I have to polymerize. Do it by palatal side, and you will have something which is spreading out. And I like very much to have some composite out of the margin, because it means that nothing is lacking inside the margin. So of course, it's a little bit of work for finishing and polishing, and you can do that very easily with the number 12 blade at first, cutting simply the excess, because the product is not finally polymerized, so it's not that hard at that stage. And then you can do your curing for 1 minute any side, and finally go with the rubber points and so on to get the final polishing. So it's quite a lot of work, but at the end you've got the best quality, and this is how it ends. You don't see my work here, you only see the work of the lab, but it's very important to show too. And we can hope that with this procedure we will get some good result for a very long time. So as a conclusion now, as this presentation is coming to its end, I would like to raise up some key points. If you use those preheated restorative composite, remember that it is always better, as a general rule, it's always better to make sure that the preps are smooth. Why? Because it helps with the precision for the lab, I mean. It helps the cement to spread out. So for the rheology of your product, especially if it's viscous, and it ensured your positioning because you've got no angles, so the veneer is coming very slowly into position. This is what you can have. If you check, you will see that with the smooth it's quite easy. It's not easy, that's not a proper term, but it's possible for the lamp to get that kind of fitting and adaptation, which is very nice. And then with the rheology, it will flow out very easily because it's smooth and round everywhere. And at the final, before polishing, this is before polishing, as you see, the margin is also undistinguishable from enamel. You've got a crack in the enamel, you've got just the margin over there, without any polishing is already very, very good. Because of the precision, because of the luting cement, this is what I truly believe. A good trip could be to keep in mind that you just have to heat your compules very high, and some people are scary about this. 65 degrees, wow, what the hell, you will just cook the pulp. No problem, because you take 65 degrees and you have 10 seconds to come in the mouth, and it's maybe 40 degrees at that time, so no problem with this. For 15 minutes you have to prepare that heating just before the cementation, and please get rid of the first extrusion of the product, because this is not so hot in the very top of your compule that is inside. So extrude, skip the first extrusion, which is a little bit more viscous, so it can create some problems. And then you can use, as you see, the very, very convenient consistency of this composite. Be very careful with the ambient light. And choose a composite which has a very long working time. So that's why especially I like the product from GEC, but also from Tokuyama, for example. Yeah, there is not only one brand, but be very careful. Some composites are just setting by themselves under ambient light very, very fast, so it could be an issue. To prevent from early polymerization, and choose the long working time composites. And finally, make sure, even if the veneer are usually not that thick, but that you use very powerful device. So I can advise you to use LED device and more than one. But the problem is when you are attacking the surface with 3 lamps, for example, you will produce so much heat that you just have, if the polymerization is about 1 minute per phase, you just have to water cool it. And it's very important after maybe the 21st seconds or the 31st seconds to water cool the preparation. If not, you can cook the pulp, yes. So this is how the presentation is ending. I think it's time now for questions and answer, and I'm at your disposal and completely ready to try to answer everything you would like to know. Thank you very much for your very kind attention.